Around. So peak and plateau pressures. These are two separate pressures that the ventilator measures. And the reason they're separate is because they represent different physiologic findings, right? The measurement they are taking represents two distinctly separate things. The nice thing about peak and plateau pressures is it can give us a clue into the patient's physiology. In addition to that, we need to manage these pressures. We don't want them to go too high because they can cause damage. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest whiteboard medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. Things like barotrauma, where the lung gets too distended, the alveoli get too distended, and as such they get damaged. But to further understand some of these concepts, it really is helpful to dive into what these pressures are representing. So if we scroll down, we drew a quick and dirty version of the lungs, right? Right side, left side. This is the trachea, the main stem bronchi, and all these bronchi obviously break up into smaller and smaller, bronchi into bronchioles, and eventually, if you were to zoom way in, this would end in kind of these balloon-shaped alveoli, right? And these are kind of balloon-shaped alveoli. That's a really terrible drawing. Let's try it again. Terminal alveoli, and these are the little balloons that actually inflate and deflate for gas exchange. This blue thing here is an endotracheal tube, right? There's a plastic tube that goes into the trachea. You blow up a balloon here so it forms a seal, right? And the ventilator delivers a breath into the endotracheal tube, right? That breath comes out of the end into the trachea. It goes into both bronchi, and then it waves its way into all the bronchi and bronchioles into the alveoli, and then it inflates the alveoli and expands the lung, right? So this lung expands out. After the breath is stopped on the ventilator, right, the lung then contracts back in, and the air goes the opposite way. So it travels back out the main stem bronchi into the trachea, into the endotracheal tube, and then out the endotracheal tube towards the ventilator. Right? That's just the basics of how a breath is delivered on mechanical ventilation. So when we're evaluating a patient on the ventilator, let's just say you're prepping for rounds in the morning to present the patient to the attending intensivist, there's two pressures that we're interested in, right? The first is the peak pressure, and the second is the plateau pressure. And these are both pressures that you can get off the ventilator. The peak pressure is often in the top right corner. It depends on the ventilator brand, but the top right corner. And it's a pressure that you get with every single breath. Whereas the plateau pressure is something you actually have to test for. You have to do this inspiratory hold maneuver that we'll talk more about to get the plateau pressure. So what are these? Starting with the peak pressure is the pressure the ventilator is experiencing when it tries to push a breath into the lungs. So ponder that for a second, right? This is a closed circuit, right? This endotracheal tube ends up coming out of the patient's mouth, and then there's kind of tubing that weaves away onto the ventilator itself. But this is a closed circuit. It's not open to the external environment, right? From the tubing to the endotracheal tube, there's this balloon that causes a seal into the lungs. So when this ventilator delivers a breath, the breath travels through the tubing, through the endotracheal tube, through the bronchi, and into the lung tissue. And the pressure that is required to flow that breath through the tubing, the endotracheal tube, these airways, and inflate the lung is the peak pressure. And that's why you get it with every single breath. Because when the ventilator pushes that breath in, it says, oh, this is the peak pressure that I experienced while I was trying to inflate the lungs on that breath. So if we think about what that means is it's really a manifestation of the airway resistance and the alveolar resistance, because those are the two things that are happening. The breath is traveling through the airways, and then it's inflating the alveoli. So the resistance of those airways and the resistance of those alveoli are what is going to create the pressure that ventilator experiences while it's trying to deliver a breath. Right? If we just make this more simplistic, let's just picture you had a pump, right? Here's your pump. It's got a little nozzle at the end, and that nozzle is kind of plugged in to a pipe, right? And then there's a balloon on the end of that pipe. The peak pressure would be the pressure it takes you to pump a breath through this pipe into the balloon and then start to inflate the balloon. Right? If you're blowing into that, the amount of force you have to push in, the pressure required to flow the air through that pipe and inflate the balloon is the peak pressure. And that is why it's a manifestation of the resistance of those airways to the breath flowing through them, as well as the alveoli resistance as they try to inflate. So really the peak pressure is airway and alveoli resistance, okay? Now, as we talked about, it's detected when the breath is being delivered, right? Because it's an airway resistance. As the breath is flowing through these airways, that is when it detects the peak pressure. And do note that this is all in volume control. This is more of kind of an advanced topic and probably outside the scope of this video. But there's different modes of mechanical ventilation. There's volume control, there's pressure control, there's SIMV, there's APRV. There's all these different types of mechanical ventilation where you can deliver breaths differently. And peak pressure is really a discussion in this context for volume control, which is the most common modality of mechanical ventilation. Okay, and the acceptable norm, I put acceptable in quotes here because acceptable is not necessarily normal. Acceptable is what we tolerate without getting very concerned and having to adjust the ventilator settings. And the acceptable peak pressure is less than 40 centimeters of water. So when you look at the ventilator and you get this reading, the peak pressure, you're going to get a reading that says X centimeters of water, right? Maybe it says 33 on that breath, 32 on the next breath, 34 on that breath. And these are all pressure measurements, right, in centimeters of water. This is in contrast to the plateau pressure. The plateau pressure is detected with what we call an inspiratory hold maneuver. So essentially what we're doing is we are pushing a breath in, and then we are pausing the ventilator. We're not letting any air out of the ventilator, and we're not letting any more air go back into the lungs. So I'm going to erase all this, and we can see if we can kind of draw it. I'm going to redraw, right? The endotracheal tube comes out the mouth. There's this tubing, right out the mouth. There's this tubing, and it goes onto the ventilator. And again, this is a closed circuit. The idea that it's a closed circuit is really important. So when we deliver a breath in, as we said, the breath travels through the tubing, through the endotracheal tube, through the trachea, the bronchi, into the bronchioles, and then it inflates the lungs, right? It goes to both sides, obviously. The plateau pressure is the pressure experienced when this breath is pushed in, but not let back out, and you pause the flow on the ventilator. There's no air flowing in or out, right? So just picture it. It's essentially if you took your own breath in, and then you just held it in your lungs. You're not letting any air in, you're not letting any air out. You can almost feel the pressure in your chest when you do that, right? Because your lungs are inflated, and your lungs are tissue. So as the air is pushing those lungs out, the lungs are also pushing back in. They're trying to deflate back down. And if you're not letting any of that air escape, the plateau pressure is the pressure that the vent is feeling as those lungs try to deflate when we won't let them. It's an inspiratory hold. So as one might assume then, that plateau pressure is more representative of the lung compliance. The compliance being how easy those airways are to kind of distend out and collapse back in. You can also think of it as kind of an alveolar resistance and lung compliance measurement. So if we think about what this is saying, the plateau pressure is actually sort of a part of the peak pressure, right? Because as we said, the peak pressure is when we push an air in, and part of the peak pressure is airway resistance, but the other part of the peak pressure is we have to inflate those lungs, right? And if we're saying plateau pressure is lung compliance, the force that the lungs are trying to push back in on that breath, you can think of the peak pressure as airway resistance plus lung compliance, plus the plateau pressure. The physiology there isn't perfect, but it's somewhat helpful in understanding these two things. Because when we think about peak and plateau pressure, we're going to talk about kind of highs and normals. An acceptable plateau pressure is less than 30, right? And that's acceptable again, because that's not necessarily normal. If you put a healthy person on a ventilator, their peak and plateau pressure would be very low, right? So this is acceptable. This is what we think is okay and will not induce a significant amount of barotrauma or overinflation or overdistension of those alveoli. So the difference between these two, the peak and plateau pressure, is important. Because if they are the same, right? If the peak equals the plateau pressure. Let's say the peak pressure is about 30, and then you do this inspiratory hold, and the plateau pressure on the inspiratory hold is also 30. That is really saying that most of the pressure that you're seeing in the peak pressure is simply lung compliance, and that there's not much airway resistance, because lung compliance and airway resistance make up the peak pressure. Right? Does that make sense? So if the peak pressure is proportional to airway resistance, right, we'll just say airway R, and lung compliance, lung C, and we're saying the plateau pressure is proportional to lung compliance. If the peak equals the plat, that just means that all the peak pressure is lung compliance and the airway resistance is not contributing. That's in contrast to if the peak pressure is greater than the plateau pressure. So let's just say the peak pressure is 50 and the plateau pressure is 20. Well, now this changes, right? Because if we're saying the plateau pressure is 20 and the peak is 50, we can essentially say that, well, 20 is related to lung compliance, but the other 30 left is airway resistance. And this can be helpful when understanding the pathophysiology going on, because these two represent different things. So anytime the peak pressure is high, the second question is, what's the plateau pressure? And if the plateau pressure equals the peak pressure, this is really a lung compliance problem. If the peak pressure is greater than the plateau pressure, it's really an airway resistance problem. And both could be high, and it could be a both problem as well, but the differentiation between the two is important in deciding if it's an airway resistance problem or a lung compliance problem. Because airway resistance and lung compliance are going to represent different things. Right? So as we mentioned, let's say there's a high peak pressure and a high plateau pressure, right? So peak pressure is 30, let's make it 50, plateau pressure is 50, that's very high. Well, remember what we said. If the peak and plateau equal each other, this is really just a lung compliance problem. Because the plateau pressure is lung compliance, and if the plateau equals the peak, that means airway resistance is not playing a big role, because we said peak pressure is airway resistance and lung compliance. So if they equal one another and plateau pressure is just lung compliance, again, means airway resistance isn't playing a role. So then we think about the things that cause an abnormal lung compliance. And that is the pathophysiology that's leading to that high peak and high plateau pressure, abnormalities in lung compliance. And those abnormalities, easy way to think about it is kind of blood, water, pus, inflammation, fibrosis, right? Blood being things like hemoptysis. If you have blood within the lung parenchyma itself, hemoptysis isn't the disease, but it can be caused by a number of things, right? DAH. It can be from any type of arterial bleeding in the lung, right? So blood in the lung can cause abnormal lung compliance, right? Because that blood gets in all those alveoli, clogs them up, doesn't allow them to distend as they would normally, right? Water, so things like pulmonary edema, P edema, can cause an abnormal lung compliance. Pus being infection, so things like pneumonia. All right, inflammation can be from anything. Let's say you have pneumonitis from, maybe you aspirate and you have aspiration pneumonitis. Maybe you're on some type of chemotherapy agent that causes medication-induced pneumonitis. So any inflammation in the lung. And then fibrosis, right? Fibrosis can cause the lungs to have decreased lung compliance. So maybe it's like interstitial lung disease causing fibrosis. So if you remember these, that gets you through most of the things that can cause an abnormal lung compliance. The other thing is if you're not ventilating all the lung like you think you are, right? So if you intubate someone and you accidentally mainstem them, right? Meaning the endotracheal tube is actually going into just one of the main stems. That means you're not really ventilating this lung. So you're trying to push all the tidal volume into a single lung, and that will lead to a high plateau pressure because that lung is exerting that much more downward pressure as it is trying to accept that full tidal volume. Similarly, if you had lung collapse of a certain area of lung, that would cause higher plateau pressure as well because you're ventilating less lung than you think you are. Or if you have had a pneumothorax, a popped lung, let's say this lung's totally collapsed because there's a pneumothorax. Again, you're just ventilating one lung. And the amount of tidal volume is the amount of tidal volume, right? Let's say you set the tidal volume at 500. That tidal volume is supposed to go into both of the lungs, right? And if it's only going into one of the lungs, so instead of getting 250 and 250, this lung's got a pneumothorax and is collapsed down. That means now you're trying to put 500 cc's of tidal volume in that one lung, and you're going to over-distend it. You can think of it like a balloon again, right? If you're pushing 250 cc's into a balloon and then try to push 500, that pressure, that compliance that it's coming back down with is going to be more robust. Okay, so if you're not ventilating both lungs the way you think you are, whether you main stem the intubation or have a pneumothorax or have some degree of collapse, then otherwise this blood, water, pus, inflammation, fibrosis are the things that can cause abnormal lung compliance, which is the high peak and high plateau pressure. And this is just to echo, right? Because the peak pressure of some of the ventilator just tells you on each breath. So if that peak pressure is high, the second question is always, what's the plateau pressure? So do that inspiratory hold. It's a button on a ventilator. You hold the button and it pushes a breath in and then it holds it. And it tells you what the plateau pressure is. Because the plateau pressure equals the peak pressure, then you know it's a lung compliance problem. Whereas if the plateau pressure is normal, it's low, so it does not equal the peak pressure, cue this other one, we know it's an airway resistance problem. I feel like I'm repeating myself over and over, but this is just to really drive home the point, right? Peak pressure is both airway resistance and lung compliance, because the peak pressure is the pressure the ventilator is experiencing when it's pushing a breath in through the airways and inflating the lungs. Whereas the plateau pressure is just a lung compliance problem, because the plateau pressure is when the ventilator pushes a breath in and then holds it, doesn't let any gas flow back and forth, right? And then that is just a representation of the lung compliance. So if it's a high peak pressure to normal plateau pressure, you already know the lung compliance is normal, right? So you're taking this out of the peak pressure equation, so you know all that's left is airway resistance, so you have an airway resistance problem. And anytime you have an airway resistance problem, what you want to do is you want to trace the circuit, I call it. Because remember what we said? We said you have a ventilator, and you have ventilator tubing. And that tubing then attaches to the endotracheal tube, right? And that endotracheal tube is going into the lungs, into the trachea. The endotracheal tube's got a balloon here and a balloon here, and it is creating a closed circuit for your lungs. So if you have airway resistance, that does not just mean airway. That could be resistance in the endotracheal tube. It could be resistance in the tubing. So the first thing you always think about is endotracheal tube pathology. Is there a kink in the tubing? Is the patient biting the tubing, making it more small? Is the endotracheal tube too small to start with? Is there mucus built up, right? Because all those things are going to increase airway resistance. I'm just going to draw an endotracheal tube, right? If you're trying to flow air through this endotracheal tube, and let's say there's mucus built up on the side, you got a big goomba right there. Now that air's trying to flow by a smaller area, and that's going to lead to more resistance. Or let's say the patient's kind of biting down on the endotracheal tube. So instead of this nice flat surface, you have this huge kink in the side because the patient's biting down on it. Again, you're going to have to try to flow that air past a smaller surface, and that's going to cause higher airway resistance, a higher peak pressure. So the first thing to do is to trace the circuit, trace the endotracheal tube. If the circuit and the endotracheal tube are all okay, well then you actually are having a true airway problem. And just like the endotracheal tube pathology, the problem with the airways could be mucus plugging, right? You could have mucus built up in one of the airways, just like you could in the endotracheal tube. Now you're trying to push air past mucus built up in the airway, smaller area to push it through, higher airway resistance. You also could have bronchospasming of the airways itself. Maybe the patient has COPD or they have asthma, right? And those bronchospasms is when those bronchi kind of spasm down, right? Creates smaller amount of area to flow that air through, higher airway resistance. Maybe there's a foreign body in the area. Maybe the patient has ventilator desynchrony. They're not being cooperative with that breath and they're kind of pushing back on it. All those things can cause high airway resistance. So again, high peak pressure Second question is, what is their plateau? If it's a normal plateau pressure, then you know the lung compliance is normal and you have an airway resistance problem. If it's a high peak pressure and a high plateau pressure, then you know it's a lung compliance problem and not an airway resistance problem, right? And that similarity between the two is if they're within about 5 centimeters of water. Now, if they are both high, right, let's say the peak pressure is 60 and the plateau pressure is 40, they're still different enough where you have an airway resistance problem, but you also have a lung compliance problem because they're both high, right? We said a acceptable plateau pressure is less than 30, and we said an acceptable peak pressure is less than 40. So they're both high, but the peak is higher than the plateau. So we know that you have both a lung compliance problem and an airway resistance problem. All right, so if you think about it that way, it sticks a little bit better, I think. And then last but not least is just the scalars. If you don't have an interest in this or don't have the background, this certainly isn't that important. But this is a pressure versus time scalar. This is something that shows up on the front of the ventilator screen. And remember, this is in volume control. And you can see here that this is 0 for the pressure. The peak pressure is going to be the peak pressure that the ventilator experiences when it's pushing a breath in, right? So this is where it's starting to push a breath in, and then it gets to this peak. And this is what the ventilator is putting on the side of it, right? This is 30, the peak pressure is 30. The plateau pressure, though, as we said, is a maneuver you have to do. So I wonder if I take a marker, I'm just gonna draw over this so we can draw something fresh. Just pretend like it's the same color as the other ones. So if you do an inspiratory hold, right, a patient takes a breath, they have the peak pressure, and then you have an inspiratory hold, the ventilator will go like this. This is when it's holding the breath. And then you let go, goes back down to 0, and the patient can take their normal breath again, okay? This here is the plateau pressure, right, this portion of the inspiratory hold. So that is literally on the scalar will give you a pressure. You know, if this is 30, let's say maybe this is just 20. Nice normal plateau pressure. And it will kick this out on the screen too. There will be a little area that says plat, and then it'll give you a number like 20. But you have to do the inspiratory hold, right? You have to hit the button. And our respiratory therapist will do this. Certainly shouldn't be doing it too much on the ventilator without the respiratory therapist, especially if you're early on in your training. But you have to do an inspiratory hold to get the plateau pressure, whereas the peak pressure is just that peak pressure at the end of each breath, and that's an automatic thing the ventilator reads. So hopefully that was helpful or interesting, or at least stimulated some additional reading. Let us know what thoughts, comments, questions you have down below. Definitely check out our Patreon page, our other related videos, and certainly we appreciate you checking it out. In any case, stay well, keep learning. We'll see you next time. All right, everybody. Welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody is doing well. Today's topic is one that a lot of people have kind of requested or brought up questions on. And it's a Mechanical Ventilation Advanced series, specifically talking about driving pressure. Per usual, quick disclaimer, this is never intended to be medical advice. Please stick around to the end of the episode or check out the episode description for the full disclaimer. And then a couple shameless plugs. We have a Patreon page. We upload the study guides to the videos, practice questions, public health, emerging infectious disease, all that good stuff. We have a weekly newsletter that focuses more on public health and emerging infectious disease. And obviously we have a YouTube page, podcast platforms, all that kind of stuff. We would love for you to check out some stuff. All of it's linked in the episode description. So dive in. We'd love to have you. Enough of the shameless plugs. Let's dive into driving pressure. What is driving pressure? Well, driving pressure is a variable that we can determine when someone's on mechanical ventilation, okay? It represents the pressure difference needed to inflate the alveoli during each breath. And we're going to come back to that as a concept. Okay, so it kind of represents this interaction between tidal volume and compliance of the respiratory system. And it's really emerged as a marker for lung stress and possible risk for ventilator-induced lung injury. If we were to kind of try to bring it down to a lower level, it's kind of the amount of pressure the ventilator uses to quote-unquote open the lungs beyond their resting state. And this definition will make more sense, I think, when we start to talk about the equation for it. We'll loop back around to it. It depends on how your brain works, but sometimes understanding the equation, how to calculate it, then helps us better understand the concept behind it. So, good transition. How to calculate driving pressure. So there's two main formulas depending on the data you have. One of these is the most common. So we're going to start with the less common formula. And the less common formula, if you know the compliance, is that driving pressure is actually the tidal volume divided by compliance. And this is a representation of what driving pressure is, but is not as clinically useful. The more clinically useful equation, which is the one that most people use, is that driving pressure is the plateau pressure minus the PEEP. And this equation is best applied to a patient who is passive, so they don't have a lot of ventilator desynchrony or interaction with the ventilator, and they're on volume control. So they can't be spontaneously breathing, they can't be desynchronous. This has to be a patient on volume control who's fairly passive. They're not interacting much with the ventilator. And what you have to do is you have to get a plateau pressure. If you do not know what a plateau pressure is, this video is probably a little beyond where you're at. We have a whole playlist on all things mechanical ventilation where we dive into plateau pressure. It's linked in this episode's description, so definitely check that out and then return to this. For those of you who do know what a plateau pressure is, friendly little reminder, you have to get a plateau pressure with an inspiratory hold. And this you kind of set on the ventilator, right? You click a little button and do an inspiratory hold, and this essentially means there's no flow of air going through the airways. You pump a breath in and then you just hold, and you check the pressure. And this is more representative of things like lung compliance or alveolar compliance. And the driving pressure then is the plateau pressure minus the PEEP being the positive end expiratory pressure. And if we really think about this, what we're saying is I'm going to push a breath in and hold it, which is going to help me just see kind of alveolar pressures, lung compliance. And I'm going to subtract the PEEP from that. And it's going to give me a number. And the lower the number, the better, which essentially means the higher the PEEP and the lower the plateau pressure, the better. Whereas if the plateau pressure is going up more than the PEEP is going up, the driving pressure will be higher, and that is worse. And we're going to circle back around to this, but I want you to kind of picture that. And maybe we'll do it now and we'll talk about it again in a second. So when we think about the plateau pressure and we think about the PEEP, lower driving pressure is better. So the plateau pressure minus the PEEP, we essentially are saying that you have this alveoli, and this alveoli is experiencing the PEEP that we set, the positive end expiratory pressure, right? This is the pressure that's there all the time, both inspiratory and expiratory. And if we set that PEEP at 5, that is going to cause the alveolus to be distended to a certain amount. And then we check a plateau pressure. And if that alveolus is perfectly distended, that plateau pressure, that inspiratory hold, that pressure that's reflective of alveolar distension, is going to be probably low. And we're going to have a low plateau pressure, and the driving pressure then is going to be lower. Whereas if we have an alveolus that is over distended because there's too much PEEP, the PEEP's at 15, that plateau pressure is going to be really high. And if we play around with this in our brains, let's say that we have a plateau pressure. Let's say the plateau pressure is 20 and the PEEP is 5, okay? And that's a driving pressure of 15. And we're like, oh, well, actually, let's change this. Let's say the plateau pressure is 30 and the PEEP is 10. That is a driving pressure of 20, right? Driving pressure is plateau pressure minus PEEP, 30 minus 10, driving pressure of 20, okay? And we're going to draw an alveolus if you're watching the YouTube video, and that alveolus is here, okay? And let's say we're like, goodness, is this the right amount of PEEP? Could they be under-distended, under-recruited, or over-distended, over-recruited? And I think, based on my clinical assessment, that they are under-distended, right? I think this alveolus is kind of collapsed down, and they're under-distended. So what I'm saying is, I think if I go up on the PEEP, that will cause the alveolus to be perfectly distended, which means that the plateau pressure won't really change, because I'm just going from kind of an underdistended, shriveled down alveolus to a normally distended alveolus. So what this would look like is I increase the PEEP from 10 to 14. And I let that PEEP take hold, and then I check another plateau pressure. And that plateau pressure maybe is 30 again. And now what I'm saying is, okay, my driving pressure is 30 minus 14, because that's my new PEEP. And that is 30 minus 14, yeah, because that's my new PEEP, and that is a driving pressure of 16. Whereas at a PEEP of 10, that driving pressure was 20. So I went from a driving pressure of 20 down to 16, which then tells me that that PEEP change was good. Changing that PEEP from 10 to 14 just helped recruit more alveoli, that before they were under-distended, because the plateau pressure didn't really go up much, even with an increase in PEEP, which made that driving pressure go down. But if we take the other scenario, right, we're going back to they're at a plateau pressure 30 and a PEEP of 10. And I think I think they're under-distended. So I increase that PEEP to 14, like I did. So the PEEP goes up, again, 10 to 14. But I was wrong. They were not under-distended. So now this alveolus is super over-distended at that PEEP of 14, and I check a plateau pressure. And that plateau pressure is probably, 36 now. So if I do a driving pressure now, 36 minus 14, that driving pressure is now 22. It got worse. It went up. And that tells me that that PEEP change is just over-distending alveoli. It's causing more barotrauma. It was the wrong thing to do, if that makes sense. We'll come back to it. All right, so what does it mean clinically? What does the driving pressure mean clinically? Well, as we mentioned, lower driving pressures suggest that less force is being used to inflate the lungs. And this often indicates the lungs are at a better compliance, more optimal compliance, whereas higher driving pressures mean that there's more force needed to inflate the lungs, and the lungs have kind of a lower compliance, aka stiff lungs or over-distended lungs. So lower driving pressures are quote-unquote good. Higher driving pressures are quote-unquote bad. And driving pressure is a surrogate for what's considered kind of lung stress, strain, associated ventilator-induced lung injury. So that higher driving pressure can suggest that those lungs are sustaining ventilator-induced lung injury, and we got to make some changes. So when we use driving pressure, the things to think about are lung compliance. And there's two different ways to think about this. Actually three different ways. One way is following the driving pressure to better understand how lung compliance is changing. So if you are not changing the PEEP, but the driving pressure is getting worse or getting better, it suggests the lungs are getting more or less compliant. So again, just scenario, the plateau pressure is 20, the PEEP is 5. Your driving pressure is 15, right? Driving pressure is 15 because it's your plateau minus your PEEP. And you haven't made any adjustments, but you check a driving pressure the next day, and the driving pressure the next day is 22. That's probably too robust of a change, but you get the point. What you're essentially saying now is the compliance has changed. Something's going on. Maybe the patient is developing worsening ARDS. Maybe they're having progression of illness because the driving pressure has gone up even though you haven't changed the PEEP. That suggests that the plateau pressure is going up. Same thing in the opposite direction, right? Let's say your plateau pressure is 30 and you're at a PEEP of 10. And for whatever reason, that's the best you could do. Your driving pressure was 20. You don't make any changes, but you check the next day and the driving pressure is down to 15. That essentially means that plateau pressure is getting better and the compliance is getting better. Whatever illness was going on is improving. Okay? So if you're not making adjustments, honestly, you can track the plateau pressure too. But a lot of times things are a little more complex, and driving pressure can be a helpful surrogate, but it can be an indication of how the lungs are evolving from a compliance standpoint, either worse or better. Okay, so assessing lung compliance. You can also use it to titrate ventilator settings, and I think that's what a lot of us do now, especially in ARDS. You could try to find an optimal tidal volume and PEEP to achieve the lowest driving pressure. And that's kind of what we were talking about, right? You can do PEEP titrations while checking driving pressure intermittently to see if the patient is, if their alveoli are optimally distended. And there's fancy things like stress index, which can help you understand this. But essentially, you're trying to get the alveoli to the most optimal amount of distension by titrating their PEEP either up or down, right? If you think they're over distended, you want to titrate the PEEP down. If you think they're under distended, you want to titrate it up. But the driving pressure will help you understand if you made the right decision. Because if that driving pressure goes down, that means your PEEP titration was good. If your driving pressure goes up, that means your PEEP titration was wrong, and you should think about going in the other direction, whether it be up or down. And then predicting outcomes, we don't use this as much, at least personally, but elevated driving pressures are associated with increased mortality in mechanically ventilated patients. So if you were to think a little bit about the evidence, this is just as of this video recording, there's certainly other evidence out there, but in 2015 New England Journal of Medicine, there was a landmark meta-analysis of patients with ARDS, and this is when driving pressure kind of came more so into the forefront. And it found that driving pressure was more strongly associated with mortality than even tidal volumes or PEEPs. So it suggests that reducing the driving pressure may improve survival in these patients with ARDS. There's been subsequent studies that kind of support this concept that you should be targeting a lower driving pressure, not just tidal volume or PEEP. But most of these are associative studies. There hasn't been, at least as far as we're aware, these robust RCTs, although they probably will be coming, so stay tuned. When we think about important clinical considerations and caveats, again, this is really only valid during passive ventilation. If the patient is breathing a lot on their own, they're desynchronous, what have you, you can't really do this. It confounds the measurements. You need a plateau pressure to do this. So you have to measure the plateau pressure appropriately, or your driving pressure will be off. And just remember, this is affected by chest wall compliance. Although the driving pressure takes some of that out of the equation, it still does take it into account a little bit. So clinical takeaways here, and then key summary points. Driving pressure is a powerful, easy to calculate variable that does reflect lung compliance and injury risk, especially in ARDS, and targeting that driving pressure of less than 15, that's your magic number, less than 15, is what the evidence would suggest may be correlated with more improved outcomes. Okay, key summary points, I think we're there. Driving pressure formula is plateau pressure minus PEEP. You want it to be less than 15. Higher driving pressure implies poor lung compliance and increased ventilator-induced lung injury risk. Best used in ARDS management. And remember, the patient has to be passive, or you cannot get an accurate measurement of this. Hopefully that was helpful. Let us know what thoughts, comments, questions you have. Again, check out that Patreon page, YouTube, podcast, weekly newsletter, and we have a whole mechanical ventilation series that will link obviously in the description on this episode, so check those out too. Either way, we appreciate y'all. Stay well, keep learning. We'll see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.